I want to continue on the existing protocol and crave your indulgence to read the citation for my mentor. Please, I would request my mentor to stand. It is not easy to read the citation of your mentor, especially when your mentor would always correct even your English, apart from your clinical studies. One of the first things Professor Essiet corrected us as resident was the spelling of his name. He said his name is Essiet, not Essiet. And you dare not write Essiet for him. This is how particular he was and how meticulous he was. I have never been able to ask him the difference between Essiet and Essiet. I think today he may want to tell us. Professor Akanimo Essiet was born more than 6 decades ago in Port Harcourt. He hails from Ikotekpene in Akwa Ibom State. He had his early education in Port Harcourt, Rivers State. This was, however, interrupted, somewhat truncated during the Civil War. But he eventually finished and was admitted to the great University of Lagos to read medicine from 1976 to 1981, where he bagged his MBBS degree. He started residency program in the University of Calabar Teaching Hospital and eventually finished the residency program in 1993, specializing in the field of urology, surgery. Professor Essiet rose through the rank and became a professor of urological surgery in the year 2009. Can we give him a round of applause? Professor Essiet bagged his fellowship, like I said, in 1993. He is a member, he has a fellowship of the American College of Surgeons, a fellowship of the International College of Surgeons. He also has fellowship in minimal access surgery and diploma in laparoscopic surgery. Most of these terms you may not understand, but just believe them. He has had a distinguished career spanning over 3 decades, with significant contribution to the field of surgery, particularly in urological and minimal invasive surgery. When we say minimal invasive surgery, we mean keyhole surgery. You use some instruments. Instead of making a big cut, you just use some devices. And he has trained many residents in that field. He was the 68th University of Calabar inaugural lecturer. He was the 46th sponsored lecturer of the College of Medical Sciences and the 3rd faculty lecturer, Faculty of Clinical Sciences. Professor Akanimo Essiet has served the university in various capacities, including, but not limited to, member of the Senate, head of Department of Surgery, head of Department of Urology, chairman of the Anti-Corruption and Transparency Monitoring Unit, the dreaded Act 2, chairman of the Academic Fraud Investigation Committee. Professor Essiet had also served creditably well in accreditation teams of the National University Commission and the National Postgraduate Medical College of Nigeria and the Medical and Dental Councils of Nigeria. He has served as accreditation team to various universities and colleges. He had also led accreditation team to NUC, Nigerian Postgraduate Medical College, and MDCN, and also had done fraud investigation work in those colleges and those organizations. So you can actually say that Professor Akanimo Essiet is the fraud czar of the university and the NPMC of Nigeria. He had been external examiner in many colleges of medicine in Nigeria, including University of Port Harcourt, University of Uyo, Ebonyi State University, Nnamdi Azikiwe University, Awka, and Nile University, among others. His research interests include reconstructive urology, minimal access surgery, surgical oncology, and surgical education. He has published extensively in reputable journals and presented academic papers at conferences at home and abroad. He is editor-in-chief of the Calabar Journal of Health Sciences, editor, Nigerian Journal of Urology, editor, Nigerian Journal of Surgery. Professor Akanimo Essiet is a member of the World Executive Council of International College of Surgeons and presently is the president of the International College of Surgeons, Nigerian chapter. Professor Akanimo Essiet has mentored many residents, some of who are consultants now, and many are equally professors, including yours truly, who is standing here. He has mentored more than 10 residents to senior consultant positions, and some of them are even professors. Professor Akanimo Essiet has also had international collaborations. He was at the University of Gambia in the year 1999 to 2000 to help establish their surgery department. And he has also had linkages with Massachusetts General Hospital, Boston, and University of Illinois. He is the lead investigator in the MADCAP program and heroic program of the International Collaboration Team. These are programs that has to do with prostate cancers in African men. Professor Essiet is happily married to his childhood wife of his youth, Professor Grace Essiet, and she's here. She was my classmate in the university. Please stand up for recognition. They have 4 children. 2 of them are currently aspiring to be consultants in different fields of surgery and medicine, and 1 is a computer scientist. Professor Essiet is an elder in the Methodist Church of Nigeria and holds the knighthood of John Wesley, KJW. Ladies and gentlemen, I hereby present Professor Akanimo Essiet to you. Thank you, sir.
Good morning, everyone. While we wait for this to come on, the chairman of council, University of Calabar, DIG Ekpo-Udom, Yo Ekpo-Udom, the chairman of today's occasion, Dr. Henry Ikechukwu Ukwe, the Vice Chancellor of the University of Calabar, ably represented by the DVC linkages who has gone. Sorry, I missed that. The chairman of council is ably represented by a past provost and former member of council, Professor Victor Ansah. The provost of the College of Medical Sciences, University of Calabar. Other members of council here present, deans, deputy deans, and other professors, particularly Emeritus Professor Patrick Ebong, my dear wife, Professor Grace Essiet, there seated, and members of my department from the other side. Now, why do I say from the other side? Because I happen to be the only member of the department on the university side. There is a young man who just finished, whom I'm grooming to bring onto this side, and I hope that he will be taken onto this side so that as I leave in a year's time, there will be somebody to replace me in the Department of Urology. Ladies and gentlemen, let me start by thanking the planning committee for this event for deeming me an appropriate person to give this keynote address in this maiden College Health Week assembly. And by extension, thanking the provosts who accepted their nomination of my good self as the keynote speaker, and further by extension, management for accepting that nomination. And so we will go into the matter for the day, which is health manpower development in a low resource setting. Strategies for survival. So health manpower development in a low resource setting. Strategies for survival. By way of introduction, let us start by defining some terms in the theme. Health manpower. This is the whole gamut of personnel involved in health services delivery, including training. It ranges from the not so specialized to the very highly specialized. Doctors, nurses, pharmacists, laboratory scientists, paramedics, etc. And they all come in their various categories. Manpower development, which you can also refer to as human resource development, This is an ongoing process that analyzes, evaluates, forecasts, projects, and addresses manpower requirements. It aims to maximize utilizable human capital and optimize their deployment for achievable strategic goals. Low resource setting, usually characterized by lean financial resources, deficient infrastructure, and nowadays, brain drain, which may be both internal and external, and perhaps therefore issues with governance. In our own case, pedagogical governance and clinical governance. So, to understand the concept of governance, governance is a term used to describe the way a group of people, for example, communities, countries, institutions, or corporate bodies, do things. Some corporate groups create a governing body to decide how things should be done. Like we have a governing council for the university, and we have a governing board for the college. Governance, we must note, is different from politics and should not be confused with politics. So if we scale it down to corporate governance, we are a corporate body, for example. This has to do with the rules, controls, policies, and resolutions adopted to guide corporate behavior. It caters to the interests of all stakeholders in the enterprise, like management, consumers of the product of that enterprise, vendors, funding agencies, governments, and the benefiting community. It provides a blueprint for realizing the objectives of the enterprise, and to that extent, would feature such things like action plans, internal controls, audits, and disclosures. So taken together, governance and issues appertaining thereto are central to manpower development. So manpower development in low resource settings. Usually, you have in such settings inadequacy of funds for training and educational programs. You would have insufficient and inadequate infrastructure like buildings, workspace, lecture rooms, equipment, etc. And of course, nowadays, you would have brain drain. And so, paucity of faculty for training programs and activities. You would usually have high patient-to-health worker ratio, high trainee to trainer ratio, and high student to teacher ratio. You have limited access to technology and information. All of these add up to limit opportunities for continual professional development, which is an indispensable element of health manpower development. So what would then be the strategies for survival in this kind of setting? Against such a background of challenges, an effective pathway to health manpower development, I would argue, should include 1, workforce planning. That is, undertaking periodic workforce analysis and projections by way of staff audits, including audit of the skills of the staff you are auditing, to identify available skills and existing skill gaps that you may need to bridge. With the outcomes of such analysis, you develop training programs for existing staff with the aim of meeting identified strategic objectives. You encourage mentorship and sponsorship in their various forms, and recruitment of relevant staff in prioritized areas of need, and putting in place actionable policies to retain such recruited staff. Recruitment of staff may be of the non-regular kind, we must note. Contract staff, adjunct staff, and part-time staff may become necessary. Such recruitment should be based on prevailing needs and in accordance with sound governance principles, devoid of political considerations. And the contract staff recruited should be seen, contract staff or contract appointments should be seen not as reward for past services, but rather as incentive for continued productivity. Part-time staff should first be sourced internally before seeking to get them from afar at prohibitive costs. Because as implied in the common street parlance, waiting day for Sokoto, a day for Sokoto, implying that what you are looking for far away may well be within easy reach round about you. The second strategy would be task shifting and task sharing. Deficiencies in health sector manpower necessitates adoption of measures to bridge the resulting gaps in the workforce. Task shifting and task sharing is one such measure and may involve, amongst other things, redefining of roles and responsibilities. For example, you may assign duties that were for one person, for one group, to another group, working on a given template anyway. You may need to train non-clinical and non-teaching staff, as the case may be, to perform specific tasks using assigned templates. For example, during exams, quality assurance duties may not be restricted to academic staff only. Administrative staff may be involved. Utilizing outposts for training and service delivery activities. For example, our Okoyong outpost can be utilized. Creation and utilization of health assistance and laboratory assistance schemes. 3 would be partnerships and collaborations. Partnerships and collaborations are possible in various formats and permutations. It may be interdepartmental collaboration, it could be interinstitutional collaborations, or indeed international collaborations. Government and private sector partnerships, also referred to as PPP, international collaborations and aid for research and service, such as the type the DVC linkages was describing earlier. Community engagement and participation, for example, community health workers programs. 4 will be utilization through deployment of technology and innovation. 4, utilization of technology and innovation. Technology can be effectively deployed to bridge manpower deficiencies. For example, you can adopt e-learning in the training of personnel, utilizing remote learning softwares, telemedicine, using phones, video services to facilitate real-time doctor-patient interactions. Now, in clinical medicine, the psychiatrists, the radiologists, the emergency medicine people, and primary care practitioners are thriving in this new and innovative world of telehealth. For example, you see a psychiatrist here consulting with a patient using telemedicine, not in-person consultation. Mobile health applications are also available for use. Virtual meeting platforms abound for training and mentoring and lecturing. You have Zoom, you have Google Meet, you have Skype, there's Cisco, WebEx, Jitsi Meet, etc. These are useful in the absence of physical space. For example, college can have a Zoom subscription that would enable lecturers to sit in the comfort of their offices to give lectures to students in various places if we don't have physical space for classrooms. This is an example of virtual meeting of the International Executive of the International College of Surgeons, at where yours truly was involved. People were participating in this meeting from all over the globe without having to meet physically. We can adopt such measures to hold our meetings and give lectures. You can also utilize low-cost medical devices and teaching equipment. For example, in laparoscopic surgery, instead of using sophisticated trainers, we can use simple manufactured trainers like the Indians have made. And then, of course, the use of artificial intelligence in the practice of clinical medicine. 5 would be staff retention strategies. Now, we are all aware that, ironically, better resourced countries are today more or less poaching medical and allied manpower from the less resourced countries like ours. Maintaining quality staffing in such circumstances becomes an issue and underscores the need for robust and proactive staffing policies, which should include competitive remuneration and benefits, attractive and workable policies on incentives, career advancement opportunities within the system, and continuing education and training programs. So to conclude, manpower development is central to the survival of any enterprise, and the health/academic manpower, which applies to us in the college, are no exceptions. Operators in low resource settings face peculiar constraints and challenges as outlined earlier. Strategies for survival should include workplace governance protocols that address 1, workforce planning, task shifting and sharing, partnerships and collaborations, use of technology and innovation, staff retention strategies. And based on this, one would recommend that we invest in health/pedagogical workforce development and take it seriously. Needs-driven task shifting/sharing protocols can be utilized as the needs arise. Partnerships and collaborations should, as much as possible, be sought for and contracted. Meaningful leverage on technology and innovation should be pursued, and staff retention strategies that are in line with sound governance principles should also be adopted. In preparing this, I consulted some literature. Thank you for your kind audience.
Can we all rise to honor our guest keynote speaker? Please, let's put our hands together for him as we rise to honor him. Keep clapping for him, keep clapping for him.